So happy Friday. Hooray, it's Friday. So welcome, my name is Jennifer Ahern. I am the Chief Officer and Permanent Secretary in the Ministry of Health, Environment, Culture and Housing. And I'm really excited to be here today for our Friday of our 9th Annual Healthcare Conference. Did everyone enjoy their breakfast? Yes, that was sponsored by BAF Insurance. Can I get a big round of applause for BAF for feeding us this morning? Very happy to have that. I do have a little bit of housekeeping. I've been passed a note, and there are 2 vehicles that are parked in the loading dock. And the problem with that is if you don't move the vehicle, they can't get to the loading dock, and we won't get our lunch, right? So you need to move these vehicles, and if you know the people who own these vehicles, please tell them they need to move their vehicle. So one is a RAV4, with a license plate number 113836, and the other one is a Volkswagen GTI with a license plate 153645. So if you are the owner or know the owner, if it's a friend, make sure they move those. So a RAV4 113836 and a Volkswagen GTI 153645. You need to go and move those right away. They are concerned if you don't move them that they might get damaged as well, as people are trying to maneuver around them. So not only will we not get lunch, you might have a banged up car. So make sure you go move that car. So we've got a big schedule planned for today. This afternoon, we've got a couple of breakout sessions that we're going to talk about 2 different topics, managing cancer follow-up care, and that's going to be in the Rembrandt room, and then a panel on taking care of the elderly, and that will be taking place here. That'll have some panel discussions with some Q&A, and you'll be getting to hear from some great experts in their field. I want to actually take this opportunity to say a huge thank you to all of our sponsors. If it wasn't for our sponsors, we wouldn't be able to put the conference on free of charge. So I want to say a big thanks to our Premium Plus sponsor, Ironshore Pharmaceuticals Inc. They're actually our speaker this morning as well. I want to thank our premium sponsors, the Ministry of Health, Cayman Islands Health Services Authority, Pinnacle Media, and Tower. If you haven't been by the Pinnacle Media booth, you need to go there before lunchtime today and enter to win. They've got a fantastic little prize. They've also got some really fun beach balls that you can grab too. Oh, and I have a found phone as well. Somebody's phone in a very nice case. And there's no identifying things on it, anything like that. So if this is your phone, we'll put it by registration. And if you know someone who's missing their phone, it's by registration. Thanks. Okay. We also want to thank Generali Worldwide for being our Wi-Fi sponsor. So if you are looking for the Wi-Fi, it's Ritz Conference, and the password is Generali, G-E-N-E-R-A-L-I, Generali. So can I get a big round of applause for all of our awesome sponsors, please? Speaking of Wi-Fi and phones, please take a minute now before we begin to make sure that your phone is either off or on silent. We don't want anybody binging and buzzing in the middle of the presentations. It's very distracting for the speakers and the people around you. Just take a second and do that. And make sure, if you haven't already, that you visit all of our exhibitors. We've got some fantastic support from our exhibitors this year. We've got opportunities in the room next door to get your flu shot. You can have a quick health check. And if you're feeling really brave, you can go and donate blood as well. You can do it all right here today. Lots of stuff going on. Make sure you thank those exhibitors for their support too. We've also got some evaluation forms. So every year we do ask you guys for your feedback. The feedback that we get helps us to make changes to the conference for the following year, helps us pick the theme, pick the topics, and look at what we need to do to make it better. So please do take a few minutes to fill out the evaluation forms. They're at the back of the room. And the CME certificates for our healthcare providers, they can be collected from the registration desk as well. So just again, a recap, we've got a lost phone that has now been found that's at registration. We've got 2 vehicles that you need to move, a RAV4 113836 and a Volkswagen GTI 153645. All right, so we've got a lot on our schedule today, so let's get it started. Our first speaker this morning, our first speakers, are Dr. Randy Sallee, who's the Chief Medical Officer at Ironshore Pharmaceuticals, and also Dr. Marc Lockhart, who probably needs very little introduction for most of the people here today, but we're really happy to have him. So Dr. Floyd R. Sallee has been Chief Medical Officer of Ironshore Pharmaceuticals since 2014, previously serving as Vice Chairman of the Department and Division Chief of Child Psychiatry at Cincinnati Children's Hospital Medical Center. As a leader in pediatric clinical pharmacology, Dr. Sallee founded the Pediatric Pharmacology Research Unit, the PPRU, at Cincinnati Children's Hospital, and is credited with supporting pediatric labeling for well over 50 marketed drugs in a wide range of therapeutic areas. He has gained extensive research experience in both preclinical and clinical drug development, and has expertise in orphan drug development, and has worked to bring new therapies to Prader-Willi, Tourette syndrome, frontotemporal dementia, and Rett syndrome. Dr. Sallee holds doctorates in pharmacology from the University of Pittsburgh and medicine from Southern Illinois University School of Medicine. He's also board certified in psychiatry, child psychiatry, and clinical pharmacology, and has authored over 100 publications in refereed scientific journals. And he's joined this morning by Dr. Marc Lockhart, who is the Medical Director at Behavioral Health Associates Cayman. Dr. Lockhart is a board-certified psychiatrist who completed his adult psychiatry residency at Wayne State University, Detroit Medical Center in Detroit, Michigan. Dr. Lockhart has been a practicing psychiatrist in the Cayman Islands for 16 years and has been in the profession for over 20 years. He is the founder and medical director of Behavioral Health Associates Cayman, or BHAC, which is a comprehensive psychiatric practice dedicated to providing the highest quality mental health services to children, adolescents, adults, and families. Dr. Lockhart serves as the Director of Inpatient Psychiatry and Behavioral Health at the Health Services Authority, where he also manages clinical duties for forensic, prison, and Spanish language services. He's a well-established member of our local medical community and holds numerous leadership roles in the country, including sitting as the chairman of our Cayman Islands Mental Health Commission, and he previously served as deputy chair of the Health Practice Commission. Dr. Lockhart received the honor of Emerging Pioneer in January 2015 at the National Heroes Day, and it was presented to him for his contribution to the development of healthcare services in the Cayman Islands. So ladies and gentlemen, please join me in welcoming, speaking on mental illness in children, empowering parents, caregivers, and healthcare professionals, Dr. Sallee and then Dr. Lockhart.
Thank you. Well, thank you very much. If you were here yesterday, you got a flavor of what it is to empower your patients. Today, we're going to have a broad survey of child mental health. And while I won't be able to touch on every aspect of the disorders that I hope to cover, will be mostly the more common ones that you're likely to encounter in your practices. So a little word about Ironshore. Ironshore is a very innovative pharmaceutical company that has platform technology in delivering drugs in very strategic ways. And the platform is called Alexis, and it involves functional coatings that allow drugs to be released in the colon while being protected in the upper GI tract. So many drugs that currently get degraded very quickly and cannot be delivered, peptides, proteins, small molecules, this technology will allow them to be utilized as drugs either directly to the colon or systemically through protection and timing of their release. The first drug that has been approved by the FDA is Jornay PM, and this is a stimulant to treat ADHD in kids and adults. And this is very unique in the fact that you give the medication at night. It is protected all night long, doesn't release, but it releases in the morning when kids wake up, or adults wake up, and it provides all-day treatment. So the formulation allows this, and it's really a revolutionary treatment in ADHD. And we think that it will contribute greatly to the improving lives of kids and families. But have a huge health impact and high cost factors for most countries. And then I'm going to give what I believe are tips for talking to your child or adolescent about their problems, and how to talk to your healthcare provider about your child. And lastly, just a review of mental health services by Dr. Lockhart in your country. And finally, concluding remarks, of which I imagine the most important thing will be the Q&A session. So children often lack the vocabulary and understanding, depending on their cognitive level of development, to discuss their inward feelings and emotions. And the task of the caregiver is to intuit what's going on with the child, even when they might not be able to articulate their problems. So I tell parents mostly to pay attention to behaviors rather than what's emanating from the child, because often there's nothing intelligible than one can gather from a discussion of their inward feelings. Many times parents and caregivers often suspect there's something wrong, and they're the most likely individuals to assess that difficulty. And those parents must be empowered how to know to seek help and how to access it. So these are the kinds of symptoms by age categories that one would likely encounter. In small children, basically excessive clinginess, fearfulness, poor eye contact or lack of social engagement with the caregivers around them, irritability, dysregulation of bodily functions, poor weight gain, feeding problems, excessive crying. For school-age children, most likely parents and teachers are likely to encounter anger, bullying, irritability, fear of separation, fluctuating mood, sleep disturbance, academic decline, sadness, and isolation. And then in adolescence, self-injury, aggressiveness, fighting, fearfulness, anger, exaggerated mood swings, difficulty with excessive or sleeping or lack of sleep, appetite changes, weight changes, isolation, and substance abuse and use. At all ages, chronic, recurrent, unexplained physical symptoms can be identified as associated with mental disorders, very persistent or disruptive nightmares, perhaps indicating some kind of trauma or abuse, regression to an earlier behavioral stage. So that's typical of children where they have progressed to, let's say, putting on their clothes, personal hygiene, self-care, and then it degrades to where they can no longer seemingly do that. Changes in sleep patterns and exacerbation of a chronic medical condition can also be associated with mental disorders. So the prevalence of mental disorders is pretty high even in children. One would think that, what could possibly be going wrong in childhood? But depression never takes a holiday, and even in kids as young as 12 years of age, 5% of the population at any one time have a diagnosable depression, and that frequency of depressive episodes in childhood increases with age up to the teenage years, where anywhere from 14 to 18% of the population at any one time might have a diagnosable depression. Similarly, anxiety disorders are also quite common, and you see that there's not quite the age progression, but throughout the adolescent years, the rate of anxiety disorder is almost a third of the population might have an anxiety disorder undiagnosed. More commonly, depression and anxiety are found in females rather than in males. So more likely, females are expressing both depression and anxiety, and those two mental symptoms and disorders tend to travel together. So if you have a patient who presents with anxiety, look for depression and vice versa. The prevalence of disorders, externalizing disorders like attention deficit disorder is also quite high, but not as high as anxiety disorders in the population. Anywhere from 3% of the population at age 3 to 5 years of age, up to 12% of the population in the adolescent years. And why the increase over time? Well, basically, it's a phenomenon of recognition, because most individuals with ADHD are identified by their externalizing behaviors, usually in a school setting. So if you're not in school, the expression of the disorder doesn't come to light, and so diagnosis is more common as you enter school age. And in the later adolescent years, females don't present with the kind of externalizing behaviors like hyperactivity or their symptoms are mostly inattention and distractibility, and so they're less likely to come to diagnosis until they reach their adolescent years. And lastly, oppositional defiant disorder, which is very commonly comorbid or traveling along with ADHD, is anywhere from 12 to 13% of the population. More commonly, externalizing disorders are found in males rather than in females. But with increasing age, the frequency of ADHD is almost equivalent in males and females as you approach late adolescence and adult years. Suicide is a very common cause of death in individuals from age 10 to 34. And you can see here ranking, the most common cause of death in that age group is accidental injury, but second leading cause of death from age 10 to 14 here, 15 to 19 here, and 20 to 24 years of age here is suicide. So very serious outcome, and one that is preventable. So suicide rates for males and females by age in the US from age 10 to 14 years of age, and this is rates per 100,000 individuals in the population. You can see males here almost always are more commonly successful because they tend to use more lethal means. The older you are, the increasingly the rates are for suicide but males are always more likely to be successful. Now, females are almost always more frequently attempting suicide, but males are more likely to successfully suicide. Let me go back here for a second. Some of the risk factors for suicide are substance abuse, mental disorder, particularly depression, and other external factors, bullying, a serious traumatic event, could be a loss of a parent, loss of a girlfriend. There's always some triggering event. The idea is for identification early and intervention. Oftentimes, kids will tell their friends rather than their parents when they're thinking about it. Suicidal ideation is very common in the population, but the key is to identify who's likely to go from thinking about it to planning it to doing it. So the time to intervene is somewhere in the planning stage. So think about some of the preparatory behaviors that go into a suicide. So if you're thinking about jumping off a bridge, you're more likely to go to that location, stand inordinately at that location, and put maybe your foot up on the railing. If you're thinking about using a firearm, you get the firearm out, not necessarily loaded, but you're playing with it, handling it. These kinds of behaviors can be recognizable, giving away your favorite items, unexplainedly telling friends goodbye, that like you're not going to see them tomorrow or the next day. It's a tragedy because in the adolescence age group, impulsivity is very much a product of lack of cognitive development, where your centers for sort of thinking long-term, thinking in the future, that this won't always be the case, that there's a way out of your predicament or dilemma, that suicide isn't the only option. Those kinds of thoughts, cognitive patterns, sort of a suppression of impulsive behaviors like running out and jumping off that bridge are less well developed. And so the older the individual, the more likely they can cognitively work through their dilemma or their stressful event, the more likely you are to prevent the tragic outcome of suicide. And many of these individuals have severe depressions that have not been recognized. It's been known that within the 6 months preceding a suicide, a high percentage of individuals have seen their primary care provider, usually for an illness, unexplained physical symptoms, lack of sleep pattern difficulties, weight loss, weight gain, the neurovegetative signs of depression. So I'm sort of reaching out to primary care providers to think about and ask your patients, do you feel safe? Are you having difficulties with any stressful events in your house? In the U.S., we always ask our patients, are there firearms at home? Where are they located? Are they locked up? How easily accessible they are? I don't know how many parents have told me that their firearms are put away safe, and kids know exactly where to go, and even know the combination to get into the safe. So I'm just going to say that asking those questions is really important. So what about genetics and mental disorder? Mental disorders travel in families, but not all mental disorder is equally heritable. In other words, Some of the genetic risks are highest for ADHD, more modest for depression and anxiety, and very low for schizophrenia. So even if you have an identical twin with schizophrenia, your risk of schizophrenia is only about 40%. Why? Because the environment has a lot to do with eventual outcomes. So, even though we're in the age of genetic testing and predetermination, not everything is predetermined, even when the genetic risk is high. Now, that being said, in a family with one ADHD child, you're likely to find an ADHD parent. And, following through with treatment recommendations can be a challenge for that household, simply because there's more than one ADHD individual conducting the treatment plan. So mental disorders are influenced by multiple genes, not just one gene. So it's very much like hypertension or obesity. And each gene, which has a impact, has only a very small impact, but in aggregate, they produce a higher risk. So even in disorders we think are distinct, like autism, ADHD, bipolar disorder, and schizophrenia, they all share some common areas of genetic vulnerability. Particularly, more recent studies have shown chromosome 3 spanning several regions, several genes are linked to all 5 disorders. But we don't have enough knowledge yet to connect all the dots, to do any kind of prediction, either for determination of outcome or for treatment. So I know several companies are out there marketing genetic tests for determining treatment or for predicting outcomes. Let me just say that what they're telling you is not exactly true, or let me say that the interpretation of the tests is less specific than you might think. They're talking, the testing companies are talking about risk, but risk is only for a population, not for the individual. So no one can, for one individual in your office to predict a treatment outcome, we're not that good yet at doing that. Maybe in the future, but certainly not now. Luckily for us, the environment has a lot to do with outcome. So changing the outcome for families, even with high genetic risk, is doable. We're not locked in to a deterministic outcome for patients and families who have, let's say, a loaded family history of depression and suicide. There are interventions that can be made to prevent those outcomes. So let's talk about the specifics of mental disorder, internalizing disorders and externalizing disorders. Internalizing disorders is where the behavior is less prominent and the internal psychological environment is the key to making a diagnosis, such as anxiety, symptoms, feeling depressed. Those are likely to produce social isolation, withdrawal, and inhibited behavior. For externalizing disorders, those disorders result in behavioral problems that are visible and identifiable and are seen outwardly in behaviors such as disruptiveness, hyperactiveness, aggressive behaviors, and they're linked to disorders like ADHD and oppositional defiant disorder. So for the internalizing disorders like depression, there are, and I know these are very common. It doesn't matter if you're a child or an adult, the identifying symptoms are the same: feeling sad, depressed mood, loss of interest, lack of pleasure in activities that once were seen as enjoyable. So when you see your adolescent being less excited about a sport or activity that they normally would be excited about. Think about depression. Trouble sleeping, many times that's the first sign of mental disorder. Trouble getting to sleep because you're so worried about some event, or trouble staying asleep, waking up multiple times during the night, or waking up too early in the morning, loss of energy, feeling all drug out, like there's no gas in the tank, increased purposeless physical activity, hand-wringing, pacing, indicating anxiety, slowed movements or speech indicating depression, feeling worthless, feeling guilty, difficulty thinking, concentrating, or making decisions. Depression can affect academic outcomes, sudden deterioration in grades, lack of ability to complete homework. That's indicating some kind of developing mental disorder. Thoughts of death or suicide. How do you make a diagnosis? There's a lot of completed screening exams by patients, parents, and teachers. These are just a list of the more common ones, and you can find these in the reference section of the slide deck when you review that at your own leisure online. And the treatments, these are behavioral treatments. These are specific manualized treatments that have been scientifically verified to be effective. So there's many kinds of therapy, but only a subsection of those therapies have been scientifically verified as being effective. Cognitive behavioral therapy, one of the more common behavioral interventions, provides patients with skills to cope with their symptoms and unhelpful thoughts, so reorganizing your thoughts and behaviors. Even in many countries with more sophisticated healthcare systems, a lot of money spent, the number of therapists who are trained to deliver cognitive behavioral therapy is very small. So it might be difficult to find a qualified therapist. Interpersonal therapy, teaching children skills to better communicate their thoughts and feelings, and dialectical behavioral therapy, a structured treatment involving individual therapy, skill groups, practicing mindfulness and problem-solving skills for tolerating distress in difficult situations. Very effective for adolescents with oppositional behaviors, with conduct problems. And of course, family therapy is also important to help families cope with the stress and difficulties associated with kids with mental disorder. Some of the depression treatments medically, from a pharmacologic point of view, there's tricyclic antidepressants, a general class of antidepressants that were available when I was trained, but they continue to be useful. Serotonin reuptake inhibitors and serotonin noradrenaline reuptake inhibitors. These are just a list of some of those that are approved by the FDA for depression and anxiety, but most of these classes of pharmacologic antidepressant agents are used what we call off-label, meaning that they don't specifically have a label in kids, but because they're useful in adults, they're often used and can be effective in childhood disorders like anxiety and depression. Some specific, more serotonergic treatments like fluoxetine, Prozac, or clomipramine and Anafranil are particularly effective for obsessive compulsive disorder. Very common anxiety disorder in kids that progresses into adult life, but it reaches its highest frequency and prevalence in the adolescent years. And some treatments and treatment guidelines are recommended by these sponsoring organizations like the American Psychiatric Association, American Psychological Association, and the National Collaborating Center for Mental Health. Once again, these are in the reference section for the slide deck that you can review at your leisure. But these are often very useful guidelines to structure your own treatment plans. And what about anxiety? There are many kinds of anxiety. Most commonly are specific phobias that are very easily treatable, to social anxieties and panic, which are not so easily treatable. But as I said before, anxiety disorders are very common in the population, to the tune of about 30% of individuals in a population will have some anxiety disorder in any given time. And they're characterized by inordinate worrying, avoidance, explosive fear, or frustration in response to a triggering anxiety, anxious event or object. And they limit your ability to function both socially and academically. Many kids avoid going to school because they're afraid to leave the house. Anxiety disorder management, once again, these are screening tools for anxiety disorders by age. So younger children use the SCARED and the MASK. These are parent self-report forms. Or older kids use other rating scale formats. Let me just say that adolescents are more likely to respond to online questionnaires rather than interpersonal questioning. So frequently, adolescents will respond truthfully to a survey, and then one-on-one, they're more likely to deny their symptoms. So just these are useful tools, and together with an interview can make a lot of sense out of behaviors and adolescent anxiety and depression. So for anxiety treatments, let's take cognitive behavioral therapy alone, about 60% effective. Medication alone, like the serotonin reuptake inhibitors I mentioned previously, are about 55% effective. But most common treatments are combined, both behavioral and medication therapies that together produce a superior outcome. So while individuals may be predisposed, families and patients, to one or other of these therapies, together they complete the picture of an effective outcome. Some of the organizations that sponsor treatment guidelines for anxiety treatment, the American Academy of Child and Adolescent Psychiatry and the Canadian Anxiety Guidelines Initiative Group, once again in your reference section. Let's briefly go, how am I doing on time?
We've got about 20 minutes.
Oh, good. So these are externalizing disorders that are very commonly identified in school-age children by teachers and parents. And the condition makes it difficult for individuals to concentrate, pay attention, complete homework, and control their impulsive behaviors and physical activity. These behaviors can be challenging for both parents and teachers. The inattentive behaviors can limit a person's academic performance and success. These individuals make careless mistakes. They're easily distracted. They have difficulty following instructions. They don't seem to be listening when spoken to. They have difficulty organizing both themselves and their activities. They avoid or dislike sustained effort, and they're forgetful and lose a lot of things. Things that you wouldn't think of. My own grandson went to a baseball game with a friend. He left with his shoes. He came back with no shoes. How do you lose your shoes at a baseball game? I don't know. But anyway, so that's just an example. Kids who are hyperactive are fidgeting around, have trouble sitting in one place. They have trouble waiting their turn. They seem to be excessively running or physically active all the time. They have trouble playing quietly. They're always noisy. They show extreme impatience. They always seem to be on the go, driven by a motor They talk excessively, they always interrupt you, and they blurt out things impulsively. These are rating scales that families typically fill out, teachers typically fill out to assess the level of ADHD behaviors in patients as young as 3 years of age or older. If your preschooler gets kicked out of their preschool, it's almost always for aggressive behavior, okay? But that's a symptom of ADHD. So think ADHD in preschoolers with difficult regulation of their aggressive impulses. For ADHD treatments, there are many behavioral treatments that work marginally well. Mostly behavioral training of parents to implement reinforcement strategies for their children. Oftentimes, that management system needs to be transferred to the classroom. Oftentimes, I talk to teachers who have very little training in terms of managing classroom behavior. So they're very good at putting together lesson plans, but when it comes to structuring a classroom to reinforce good behavior, not just in kids with challenging behaviors, but the classroom in general, I find that their training is woefully lacking. Oftentimes what I wind up doing is taking the behavioral plan that we've developed for parents and then transferring the same behavioral reinforcement tools into the classroom with teacher input. And then more specialized or peer groups, so like a skills training group of kids where you have some individuals with disorder and then kids without disorder in the same peer group, so they learn skills for effective communication, collaboration in a group setting, and organizational skill training. Teaching kids how to, particularly adolescents, how to get themselves ready for school the previous or the preceding evening, getting all their homework organized. What kind of organizational tools do you need to be successful, whether that's setting a timer on your cell phone or other strategic tools. Teaching adolescents how to do that often involves a specific training skill set. And then there are medications. Medications are particularly effective in oppositional defiant disorder and ADHD. I guess for the last 35 years, I've worked with stimulants in ADHD treatment, and I can say they're highly effective to the with effect sizes that almost approach 0.8 or 1. So that's as effective as any medication interventions for any disease across all medical categories. And over the years, we progressively increased the span of treatment by producing timed release medications. So when I first started in residency, we only had immediate release, short-term interventions of, let's say, methylphenidate/Ritalin that we would have to give 3 times a day. And this is a real challenge for parents and teachers to give that medication those many times per day. The revolution in treatment was extended release treatments. So when I first started, almost 100% of medication treatments for ADHD were immediate release. This day and age, 85% are extended release treatments, meaning they last 5, 6, 7 hours during the day. Maybe a little longer, but those are usually the effective time ranges. The challenge is to cover the entire day, from the time the kid wakes up to the time they go to bed. And so the intervention that we think Ironshore could be incredibly useful to revolutionize the treatment of ADHD from the time the kid wakes up till the time they go to bed. So this is what we call a delayed release, extended release stimulant treatment. Non-stimulant treatments are also pretty effective. To the tune of about 50 to 60% of individuals will respond to those treatments, and usually they consist of either the SNRI, the atomoxetin or Strattera, or the alpha-2 adrenergic agonist, guanfacine or clonidine, in an extended release form. These are the guidelines put together by the American Academy of Pediatrics, Canadian ADHD Research Alliance, and National Collaborating Center for Mental Health in the treatment of ADHD and ODD. And I would refer you to those guidelines for your own investigation and perusal. ODD is oftentimes comorbid with ADHD, and it consists of a persistent pattern of angry, irritable mood, argumentative behavior, defiant behavior towards authority figures and adults, and exceeds the typical range of a child's age, gender, and culture. So kids with ODD tend to have a very short fuse. They're often easily angered. They frequently are easily annoyed and often resentful of adult intervention. They're argumentative, defiant, often deliberately annoy or upset people, often blame others for their own misbehavior or misdeeds, and are often vindictive. Now, once again, we see this as a disorder, not necessarily a personality trait. So when I find I'm annoyed with a kid for no particular reason, think ODD. About 30 to 50% of children with ADHD also develop ODD. Now, ODD and conduct disorder are related, but they're not naturally a progression of one to the other. So the time to intervene for these types of behaviors is very early on in a school-age child. The diagnosis can often be made by many of the same tools that you use for ADHD, the Conners rating scale, the Vanderbilt diagnostic rating scales that often are infrequently used by parents, teachers, and pediatricians, and the child behavior checklist. So how is ADHD treated? Once again, very similar tools to what we use for ADHD: cognitive behavioral problem solving, social skills training, and parent-child interaction therapy. Once again, the idea is to give parents the tools they need to effectively manage their children and reduce oppositional behavior. And I tell parents not to pay attention so much to what a child says, because oftentimes this vindictive, argumentative behaviors are just peripheral to behavior. I tell them, pay attention to what the kid does, not what the kid says. So, and limit your battles. Fight the big fights, don't fight the little ones. Don't get yourself worn out. Oftentimes parents feed into the bad behavior of their children because they get caught up in it, and it's a vicious cycle of ineffective interventions that make the parent frustrated and de-energized, and the child frustrated and escalate their own behaviors. So these are the guidelines, once again, very effective guidelines for the treatment of ODD, mostly behavioral. Now, these are the less severe, or less frequent, but more severe and disabling conditions of autism spectrum disorder, which is a developmental disorder which results in lack of social, I would call it social cognition. deficits in communication, social interaction, and restrictive and repetitive behaviors that normally first presents in very early childhood. So there are effective screening tools for kids as young as 2 and 3 years old to look for autism. Early intervention is best for positive outcomes. Eating disorders, which involve persistent abnormal eating patterns that negatively impact physical and emotional health. Eating disorders such as anorexia or bulimia are most frequently developed in the teenage years. And anorexia can be life-threatening. Bulimia is very common in adolescent females. Once again, these are serious health conditions. Not terribly frequent, but can have tremendous impacts. Schizophrenia, more likely to develop in late adolescence and early adult life. It's a disorder of abnormal thoughts, interpretations of reality, can include hallucinations, both visual and auditory, with extremely disordered thinking and behaviors. These disorders as a group impact every area of an individual's life. Often these kids have increasing propensity for self-harm, and these disorders can lead to death if not intervened with. The treatment is often very specialized and requires the involvement of specialty mental health resources. So how to talk to your child? Start by being curious. So there's a fine line between being curious and being nosy, but ask questions and be interested in the response without judgment. Try not to be judgmental. Try to make the environment safe for a child to confide in you. Show trust. Look for opportunities to demonstrate that you trust your child. Don't be a dictator, be a collaborator. So offer suggestions, but don't try to fix things. Don't try to problem solve all your children's difficulty. Let them troubleshoot with suggestions from you. Give praise, strategic praise. Both children and teens respond to strategic appraisal and self-esteem boosts. Control your emotions. So if you're in control, you're more likely to be an effective parent. Being emotional makes it harder for you to think and respond critically. A very effective technique is to say, I don't know, that you've given me a lot to think about. Let me think about it and I'll get back to you. In other words, if you're stumped as to what answer to give, just say time out and you'll get back to them because it's a very important problem. Don't try to think on the fly. Being emotional doesn't help. Just try to stay calm in your talks with your children. Taking time to talk to your healthcare provider. Be informed about the disease condition. Seek evaluation if necessary. Ask your child's primary care provider if your child needs further evaluation. And ask them how much experience they have with behavioral problems that your child seems to exhibit. Ask the right questions before beginning treatment. What are the goals of this treatment? How much experience do you have? What's the evidence that this treatment is likely to be effective? How will we measure how effective it is? How long should we expect the treatment to last? What is our role, meaning the parent's role, in the treatment? What are the possible adverse consequences or adverse events, and when would they likely appear? So if your child has depression, starting antidepressant, the first 2 weeks are critical. The depressive symptoms might actually increase during this period of titration. And the most critical period for judging medication effectiveness is not the first 2 weeks, it's the 8 to 10 week period afterwards. So be thinking about when you should be looking for treatment outcomes and when you should be on your guard for adverse events or side effects. So these are the slides that Dr. Lockhart is going to present, and then we're going to follow up with Q&A. Thank you. Dr. Lockhart.
Good morning, everybody. Let's give another little round of applause for Dr. Sallee. That was a wonderful talk. His slide on how to talk to children, I think you should save that slide. I think that's excellent advice. Want to welcome everyone, and I want to also thank, again, Dr. Sallee and Ironshore for their partial sponsorship of this wonderful healthcare conference. I'm here to talk a little bit about our mental health system here in the Cayman Islands, and just a little background. We're a population of approximately 65,000 people. In Dr. Sallee's talk, you notice that there are some major themes. He spoke about the genetic component to mental health disorders, and some more heavily weighted than others. But if you notice, he spoke a lot about environment and behaviors. Our environment of 60,000 people, about half of our population are from different places. Half of our population is an expatriate population, and we are a very diverse and multicultural society here. I would say that although we're a very small little dot in the ocean of the world, we're a microcosm of what really a multicultural society should be. We have our frictions, we have our differences, but we don't have hate crimes. Fortunately, we're not killing each other and battering each other. We argue a lot, we talk a lot, we chat a lot, which is part of our culture, but I think we're working things out. From a mental health perspective, we've come a long way. Our population has grown by 70%, Dr. Sallee, in the last 20 years, and 14% in the last 4 years. That's really unheard of in any other place in the world. That puts a certain environmental pressure in terms of adjustment. We speak many different languages in the Cayman Islands. We have many different cultural practices, but we, because of our size, have to integrate. We don't have a little Filipino area. We don't have a little Chinatown. We don't have a little Jamaica town. Some may say there may be certain areas like that, but we have to integrate as one. That integration puts pressure culturally on us acclimating, and we're seeing some of those changes. We have an 8-bed inpatient unit at the Cayman Islands Hospital, and that is our only inpatient psychiatric facility. Again, for a population of 65,000 people, that's not sufficient. A recent consultant study of the hospital, because we're working on improving that, highlighted that the psychiatric inpatient unit is the only unit in the hospital that runs almost at full capacity constantly. That puts pressure on the staff, and I'd like to give a special shout out to the nurses, therapists, and staff at the Health Services Authority for what they have to deal with. We do have public and private facilities. Most of the private facilities actually see the larger numbers of outpatients that we're seeing. And again, I'd like to also really give a bold and strong support and thanks to the behavioral and mental health fraternity in the community, all the private members and all those that are here, again, for the work that you do. We have many challenges. We are working on gathering lots of information. We have many partners, as the slide shows, in the community. The Alex Panton Foundation is one. which is a foundation that is working towards identifying areas of need and directing financial and other resources to those areas. We have Loud Silent Voices, which is a consumer support group here, which is very similar to the NAMI Association in the States. We have the Cayman Special Needs Foundation that also does a lot of work in the community. As I said, we only have an 8-bed unit. That is not sufficient. That's a major challenge. It leads to more recidivism and the revolving door type of treatment. We have realized that we do need longer-term type care for those with more serious types of mental disorders. And one area that we're realizing that we really need to address are the young people. So some of the recent statistics that we're just in the process of correlating are highlighting that there's been an overall increase of about 5% just in the past year in the numbers of total cases of mental disorders that have been treated. When we break down that 5%, we find that the groups with the highest growth are 16 and under, with a 12% increase over just the past year. And the 16 and the 17 to 19 age group, that increase has been 11%. So we're seeing that the younger age groups are having quite an increase. Part of that is early and better recognition, increased professionals. But it's also showing that some of the interventions, both medication and therapy-wise, that we require for our young people are very warranted and necessary at this point in time. We do have plans through the Mental Health Commission and with the Ministry of Health to move forward with a long-term care facility. That long-term care facility is focused on real rehabilitation, in addressing all of the needs in a very comprehensive and holistic way. There are a lot of other things, but I think we should probably stop at this point and open up for questions.
Thank you so much, Dr. Lockhart and Dr. Sallee. Can I get another round of applause for them, please? Unfortunately, we don't actually have time for Q&A, but they'll both be around during the coffee break, so I'm sure they'll be happy to speak to you if you have any questions then. I do have a small token of our appreciation to present to both of you. These speaker gifts have been very generously sponsored by Kirk Freeport. We want to thank you both very much for a very informative presentation. Okay, how's everybody doing? Good. There was a lot of information in that presentation. I saw a lot of you taking photos of the slides, but as Dr. Sallee and I think Dr. Lockhart both mentioned, the presentations are going to be available on the conference website after the conference is over, so don't despair, you'll be able to capture it again after the fact. So we're going to move on to our next speakers. We've got James Malicoat, who's the Director, the Consultative Executive at Cerner, and we have Keith Higgins, who is the Chief Information Officer at our very own Cayman Islands Health Services Authority, and they're going to talk to us this morning about the patient portal. So James Malicoat is, as a consulting executive, he has responsibility for 12 consulting teams at Cerner that include Healthy Life, ePrescribe, Clairvia, Encode, ED Charge Ticket, Health Maintenance, Helix, Infection Control, Power Touch, Core, Apache, and Ambulatory Reference Lab Network. He oversees and helps define consulting strategies across these teams while driving IP requirements, sales, revenue generation, and client relationships. During his time at Cerner, James has played an important role in Cerner's consumer-facing solutions. He has over 15 years of experience in this space and has been a leader in the patient engagement strategies. He led Cerner's first implementation of the patient portal and was also the project owner of the Juvenile Diabetes Initiative, where he helped create and manage the Tackle Diabetes program. Most recently, he was responsible for managing and overseeing the implementation of the Healthy Life portal across the entire client base to make sure that clients met key meaningful use requirements. James is also responsible for a new consulting offering geared towards helping our Healthy Life clients create a more meaningful Healthy Life portal. This new offering has helped clients realize additional RIO, return on investment, and add value and increased patient engagement. And he's joined by Keith Higgins, who is the Chief Information Officer at the Health Services Authority. He's a member of the senior management team providing strategic leadership in the organization's continued development of an innovative, robust, and secure information technology environment to meet the clinical and administrative needs of the island's premier healthcare system. In his 8 years with the HSA, Keith has leveraged his experience in customer engagement in the financial services sector to lead the HSA's effort in patient engagement through such initiatives as an online patient portal with patient appointments and reminders, the first in the Caribbean. Keith has been instrumental in the organization's transformation from an archaic manual system to being at the forefront of technology-driven solutions and a leader in clinical information technology, IT infrastructure and services, information securities in the Caribbean. As Chief Information Officer on an island nation, Keith's duties are unlike those of traditional Chief Information Officers with a narrow focus on IT infrastructure and systems. But he encompasses a much wider breadth of responsibilities, including call center and patient engagement, building automation technology and security, patient entertainment, and the education system. Ladies and gentlemen, they're going to speak to us this morning about the patient portal, our patients' engagement demand. Please welcome Keith Higgins and James Malicoat.
Good morning. Can you guys hear me? Yes? No? There we go. Hi. Thank you for having me. I'm going to put my phone here so I can keep track of the time. I'm going to come down here and talk. I'm better at kind of walking and talking to the audience versus standing up there. So again, James Malicoat from Cerner. First, I'd like to thank the conference for having me, and I'd like to thank the Cayman Islands for being such a beautiful place. Oh my goodness. And also thanks to all the people I've met here. So nice and friendly. So thank you for that. Today, I do want to just quickly tell you about Cerner in a nutshell at a very high level. So think of Cerner as a technology information company where we work with our clients to basically digitize healthcare and make everything paperless. So from the doctors and nurses using our solutions, to the electronic medical record, to the front desk staff, and then also reaching out and touching the patients and the consumers. And so today, as we talk through the patient's demand and to serve technology in healthcare, that's what we're really going to focus on. So I'm going to start with a quick little story. And if you look up here, these are my daughters. So the one on the left is Sydney, and the one on the right is Molly, and the one in the middle is my only son, because I have a house full of girls. And that is Jax, my golden retriever. This picture was taken a few years ago, and the title of this picture is "Roll-Up Windows Are Cool." So one day, my daughters came home, and they were so excited to tell my wife and I this story, and they said, "Oh my gosh," they're like, "our babysitter got this car, and it's so awesome." And we're like, "What's so awesome about it?" And they're like, "They have this handle, and when you do this and you turn it, the windows go up and down." So my wife and I kind of looked at each other, and we laughed, and we said, "What?" And they just thought it was the coolest thing. So, you think about technology, you think about our children, they don't even know the difference in some of these things. So we're going to kind of keep that story in the back of our minds as I wrap this up at the end here. But when I put the screen up here, I think all of you look at this, and we know technology today is the norm, right? I would guarantee you that everybody in this room probably uses one of these solutions. Raise your hand if you use at least one of these solutions on that screen. Okay. So with technology being the norm, and with technology being the norm for consumers, the one thing I'll say is technology is probably not the norm when we talk about healthcare. And as you look on the screen, I go back to thinking about my daughters. If I tell them to go to Blockbuster and rent a movie, they're going to be like, what are you talking about? Or go buy a cassette. They don't know what a cassette is, or CD. So as we look at this screen, again, it just reminds us that we're 3 clicks away from doing everything. So why is healthcare not there yet for consumers? And I did actually put Snapchat there on the bottom. I do not use Snapchat, but apparently old people use Facebook still, and young people use Snapchat. So I had to put that on there just to pretend like I'm kind of cool. So as we think through the consumer and current experience today for a consumer in healthcare, so if you'll look there on the highly fragmented side, as we think about healthcare, that's where we're still at today. And I say we're still at it today because I do think we've been on this trend. And remember, I've been rolling out patient portals and consumer experiences with Cerner for 15 years. And I remember the first patient experience or the first patient portal was we would give people a CD. They would download it to their desktop, and we expected them to type in all of their allergies and immunizations, and then keep track of it and print it off and take it to your doctor. That sounds so archaic, right? Then we had this personal health record where we let you type it in online and maybe we could share it. And now that we've digitized the data, we have a whole new experience where we're going. But it's still very fragmented today. And what I mean by that is we still have probably 5 different usernames and passwords to get into 5 different solutions, to go check my insurance, to go check my patient portal, to go pay my bill online. And if you guys are like me, I keep all of those like in a little Outlook card, and I try to organize it. But we don't want to do that anymore. We should have a single place to go to and interact with our healthcare providers. So rising expectations, as you see there in the middle, we talked about that a bit. The market is completely different. And again, healthcare is not there yet, but I do think, we've been climbing this hill, and I think we're about at the tipping point of the roller coaster. And it's very exciting for me because doing this for, 15 years and the experiences I've had talking with clients and where they're at and where they're going, I do think we're on the very edge, about to go down that hill. And when we go down that hill, it's going to be fast. So for healthcare organizations here around the world, I think it's going to be exciting. I think it's going to be great for the consumer because I do think you're going to see a lot of changes come very quickly over the next couple years. The race is on, and I put that up there just because I do think the race is on, and as you know, we are all connected at the hip to these things. I barely can set that down. I got to keep it in my pocket. But we're connected at the hip to these things, and when we turn that first screen on, we all have our little favorite icons, right? I can probably bet in this room that none of your favorite icons on that first screen is probably your patient portal. I could be wrong, and if anybody wants to prove me wrong and hold their phone up and show me that first icon on that first screen is your patient portal, please do so. Okay. Second screen. Oh, we got a second screen here. But basically, I guess what I'm saying is until we get better, until we have, and some of it is just simply as a consumer, we want more, right? We want a better connection. We want more tools. So as we talk through today, I'm going to talk about some of the neat things we're doing at Cerner and some of the great things that we're going to be doing with our partners at HSA going forward in the future. So real quick, the Black Book Market Research, they do lots of different surveys. And if you look at this quote here, 88% of patients under the age of 40 said they will choose their next provider based on online presence. So think about that. So as a healthcare organization, these folks have choices. And if this organization over here is going to give me all the tools I need, like the Netflix of the world and the Amazon Primes of the world, then I'm probably going to go to that organization versus another organization because it's more convenient for myself. And again, technology is the norm. This is the environment we live in, so we have to be thinking about that when we're rolling these solutions out. And the second quote there, 92% of respondents said improving consumer experience should be a top priority for healthcare organizations. This survey was taken 2 years ago. 71% said that exact same thing 2 years ago. 92% said it this year. So the increased acknowledgement of technology in healthcare is, again, is going to be the norm, and we have to make sure we're providing solutions and services to our patients that allow them to interact. So what does everybody want? Well, as a healthcare system, they want increased market share, engagement, and in-network retention. That's, of course, important to run a business. They want to optimize operations and create efficiencies. And they also want to deliver high-quality care and maintain people's health. Those are, again, very high level of every healthcare organization. So as a consumer, what do we all want? As consumers, we want a personalized experience. So when Netflix sends me that message and says, hey, I know you watch these 3 shows over here, you should probably watch this one, you're going to like it. And they're right every time. It's crazy. I don't know how they do it. But it's data. And remember, we've digitized the data now. We have all of this data. Why are we not using it more? So a consumer also wants convenient, modernized access to their data and to their healthcare providers. Reduce the hassle factor, which is a big one, hassle factors, and we'll talk about that in just a bit. And then also high-quality care and high-quality health resources. So again, kind of that what does our organizations want, what do our consumers want, so how do we get there? So as we look at this, what we've done at Cerner is we're creating a single healthy life framework. When I say healthy life, that's what we call our patient portal. So that's kind of an interchangeable term for us. But when we think about this framework, what we want to do is we want to create a single user experience. So again, I guarantee you in this room, we have 5 different logons and usernames for 5 different applications that somehow get us to our healthcare. So what we've done is we create this single logon, so that single experience allowing you to log in and access multiple pieces of data. We also want it to be contextually aware of who we are. So if I log in and I'm a male over 40 and I haven't had a certain test done, then tell me. Put it up front. Let me know. Maybe throw an article out there about a certain thing that maybe it's a first-time mom for breastfeeding, something like that. Put an article out in my portal when I log in. So again, contextually aware of who I am. You have all the data on me, so let's start pushing some information out. And then lastly, this framework that we're creating, we call it an extensibility framework. What it does, it allows you to plug and play different pieces into this single log-on access. So we at Cerner don't think everybody's going to use Cerner. I mean, we're not that stupid. So there are lots of other partners that healthcare organizations use. But in this framework, we want it to be that trusted location that you log into, and you can message with your doctors, you can do appointments, you're able to go do your online bill pay. So lots of different pieces, and that's not all Cerner, but we can plug and play into this extensibility platform. So you're still just logging in that single location, and then you have access to, you're not using 5 different usernames and passwords to go do all your bits and pieces. So when we talk about reaching the individual, a couple things I'm going to run through and just talk through. First of all, the trusted brand. Again, a trusted brand for me and that I've chosen is Spotify. I like Spotify. You might be a Pandora person. I chose to pay the Spotify premium because I like Spotify. So as I think about that, and I've got that on my phone, it's, I go click that, and that's where I do my music. So we want that to be the same thing for your healthcare organization. So it can be branded to that organization site. So that's one thing we're going to be working with HSA on. Direct book scheduling. I tell clients all the time, and it's almost funny. It's like, do you realize that I can go online and book my dog an appointment with the vet, and you're not letting me book an appointment at your organization? Now, HSA has direct book scheduling turned on, so that's awesome. But lots of clients are still, slow to kind of adopt that. But again, let the consumer, it's technology, we should be able to do that online. Video visits is changing the way that we're interacting with our healthcare organizations. We'll talk about that. And then Clipboard I'm going to run through. So these are some features that we have turned on across our client base. And again, as we partner with HSA to get some of these things turned on. So when we talk about video visits, this is one of those. We recently did a study with the University of Missouri where they've seen a 52% decrease in no-shows on appointments when they've direct booked these visits online. So that is money to an organization, if you think about that. I mean, a no-show costs an organization a lot of money, but if you're a consumer and you've taken the time to go online, log in, and book it, you're more than likely going to show up for it. And a video visit's going to also help them maximize session time. So if I'm sitting in a private room, I'm maybe at my house versus driving an hour across town to go do this and driving an hour back, I've now missed 2 hours of work. I sat in the waiting room for 30 minutes. A video visit is so much easier. Now, of course, you're not going to do a video video visit for everything, but the simple things that we can do video visits for, let's open it up and allow video visits to happen. Expanded availability. That's another piece where whether you want to expand some hours in the morning, you want to expand some hours in the evening, we've seen organizations use this to grow business at a certain clinic. So maybe a clinic is not as busy on a Thursday from 3 to 5. Open up some video visits from 3 to 5 at that clinic, and believe me, they're going to get taken up very quickly, and you've now increased the business at that organization or at that clinic during that time frame. And let us direct book these, right? Why not be able, why shouldn't I don't want to call a calling tree, stay online for 15 minutes, they don't have my appointment, so then I've got to, restart that. My screen's a little different down here. That one. All right. So Clipboard, as we get into Clipboard, the next piece of this technology and what we've seen really expand and change the way we're interacting with healthcare. So how many of us have shown up to a visit and they hand you that piece of paper and you fill that stupid thing out over and over, and then you hand it back to them and they go in and they type all that in? So this happens all the time. So when we think about Clipboard, what we've done is, and I'll try to keep this in terms that make more sense. So within our electronic medical record, we have forms that the doctors and nurses are filling out when they're asking you that information a lot of times. So what we've done is we've taken that form and we've made it viewable in the patient portal. So now, instead of me showing up 20 minutes early to my appointment and filling that piece of paper out, I'm actually able to fill all of that out online in my home and at the convenience of when I want to do it and have access to things. So as I look at Clipboard here and I think through, I can actually do med reconciliation now as a consumer. So when I'm going and filling my meds out, maybe I didn't have that med bottle at the appointment with me. I didn't know what it said. I can't remember what it was. I can just go in my house, grab it, and fill it in. So all of the data in these clipboards now is discrete data. And that's what's key. And that's what's key to the organization. Because today, when you're filling that piece of paper out and you're handing it to somebody at the organization, they're going in and retyping all that in. So think of the time that you spent on it. Think of the time they spent retyping that in. So what we've done is we've taken these forms. They're now discrete. As a consumer, you can fill that out online at your convenience in your mobile app, on your desktop, whatever, your laptop. And that data then shows up in the electronic medical record as a power form. And that's what we call those on our end. And in that power form, the doctor and nurses can now review that information. When they click that button, it discreetly drops that data right into Millennium. So again, think of the time the organization is saving from retyping that information in. The nice thing about these clipboards is that they can auto be attached to appointments. So if you go direct book your appointment, it could pop up and say, hey, we have a clipboard for you. We want you to fill this out before you come in. Or if a clinic staff member books an appointment for you, it can, and it happens to be like maybe a diabetic follow-up or an annual physical or whatever. These are custom clipboards that we create on the back end that are auto-connected to that appointment type. So you'll get a reminder to fill it out. If you don't fill it out within 2 days of the appointment, you'll get another reminder. Those reminders can be sent to you via email. It can also show up on your app on your phone, which we're all connected to 24/7, and tell you, make sure you fill your clipboard out. You can do it right there. And quite frankly, what we've seen a lot of our clients do is they're saying, if you show up to your appointment and you didn't fill it out, they're going to say, do you have a mobile phone? We all say, yes, we have a mobile phone. Log into your patient portal and fill it out while you're sitting there waiting for your visit. So again, discrete data, click a button, drop it right into Millennium. Or the electronic medical record. Again, that's another term. Millennium is what we call our electronic medical record. So just real quickly, some of the things: family history. You can have forms for family history, medication. You can see review of systems. So all of these things, all of these forms that they're using today on the physician and nurse side, we can present those to the patient in the patient portal. Much easier, a better way to fill this out and get that information into the chart. So when we think about a seamless experience for patients, I think a lot of times when we talk about patient portals, I think people think a patient portal is a subset of my information, right? I only get a little bit, I don't have everything in there. Well, I'm here to tell you that in the patient portal, you can see everything if the organizations turn it on. And sometimes I think having those conversations with the organizations, and those are changing, believe me. I would say even as early as 3 to 4 years ago when we talked to organizations, they're like, don't show those labs for at least 72 hours. Someone's going to, again, remember, I could walk down to the HIM department and get my entire record printed off, right? Why shouldn't I be able to see my information online? So I am here to tell you that a seamless experience and having more data turned on, all of the data turned on, clinical notes, lab results, pathology reports, everything turned on in the portal is what a consumer wants. We want access to it's our data, right? So why don't we have access to it? So again, this seamless experience is important. The more data we turn on, the better. It's going to help in our care management. It's going to help as we start notifying patients of more data. And you'll see here, notifications is another piece I think is important because we as a consumer like to be notified certain ways, right? So I'm a person who maybe likes to text more than email. So in our system, we're going to allow you as a consumer to tell us how you want to be notified. So do you want to be notified when you get a message from your doctor or nurse? Me personally, yes. If someone sends me something, notify me. Maybe I don't want to know when a clinical note posts to my record. So as we know, multiple solutions sometimes notify us too much, and it's kind of overkill, and we want to turn those off. So within the system, you're able to actually go in and say, notify me this way, notify me for these things, and here's how I want to be notified. So I think that's important as we think about that as we connect with the consumers. And then the other thing is, I think is really, you've seen over the past couple of years, is devices, right? How many people in here right now are wearing some sort of device that tracks something? Raise your hand. Steps, okay. And I actually saw a lot of people signing up out there to win that Fitbit, so some of you, I know you want one of those. But this is another important piece I think we need to get to. So a lot of us are out buying these devices. We're tracking whether it's for just our own pleasure or whether it's actually tracking a condition. So what we've done is we've integrated devices a couple different ways. We have the BYOD, bring your own device, is what we like to refer to that as. And that is, we've got 150 different devices that are already connected. So these are these important devices like that you all probably have, your Fitbits, your Garmin watches, your Apple watches. So we can connect all of those, and that data can actually flow directly into the chart. So now we have data flowing from your devices right into the medical record that we now can track and we can work with you on and follow up on. And then we also have a prescribed device model where, let's say you're maybe a diabetic or maybe you have congestive heart failure. We have a box of devices that we can actually give that patient. And when they go home, they actually plug this little Bluetooth thing into the wall. They pull out the scale, they pull out the blood pressure cuff, and as soon as they put that thing on or as soon as they step on the scale, that data flows right into, it's already Bluetooth connected, and it goes right to the chart. So devices are going to change the way that we work with our patients going forward. So this is exciting, and we're already doing this with a lot of clients. And I think it's important because I think a lot of us are really starting to, and you see Apple and Garmin and all of these companies getting into the healthcare business with these devices. So it's going to be a big trend as we go forward. So I'm going to leave you just with a couple quick things. So this quote here, the best way to predict the future is to create it. And the reason I say that is because, as a healthcare organization, as a consumer, we will move forward with technology. And as a healthcare organization, if you want to stay connected and you want to be that trusted advisor for the consumers going forward, then go out and create it. Turn these things on. Let your patients be connected this way. It's important for them. We see it in our everyday use of everything that we do. So again, I urge everybody, go turn these solutions on, let them be connected, because this is how they're going to move forward, and this is how they're going to pick their healthcare organizations going forward too. So I'm going to wrap up with this quick story. I'm back to my daughters. So as you can see, that picture I showed in the very beginning, that was taken 4 years ago. They've all three grown a lot. I think the dog might have grown the most. He's about 95 pounds now. And my daughter is now driving at 15. She's 15. My other daughter's 12. At 15 in the state of Kansas. Yes, I'm from Kansas. I know you guys feel sorry for me, especially when being in the Cayman Islands. But at 15, you can drive now. And believe me, she is super excited that she does not have roll-up windows in the car she has. And not only is she super excited about it, we actually reminded her of that story. We said, remember when you came home and told us about those cool roll-up windows like 4 years ago? And I'll leave you with this. When we turn on technology in healthcare, Do not turn a patient portal on that has roll-up windows, please. It is important to turn a patient portal on that has technology like we want to use it. So I'm going to hand this off to Keith Higgins. So I appreciate you guys having me today. And Keith is going to actually talk about the patient portal evolution at HSA, and how they've rolled it out and how we will continue to partner with them to turn on all of these great features so you as all patients can use some of these next pieces of technology. Thank you. Oops, sorry, Keith.
Thank you, James. Thank you, James.
Oops.
Can you hear me? All right, yes. Thank you, James. What James just delivered was what Cerner is doing with the patient portal. My job today is to tell you about what HSA's journey has been with the patient portal. So what I will do is I'll take you through our evolution with the portal. My first disclaimer is that I'm an employee at the HSA, and I don't work for Cerner, and I don't have any shares in Cerner. So if I promote their product, it's just by chance. The goal of the presentation is, firstly, I'll give you some information about HSA, and then I will show you some features of the portal, and I'll follow that up with our journey and giving you lessons learned and the hurdles and challenges that we had. And then I'll tell you what the future holds for us at HSA on our patient engagement strategy. HSA. A quick show of hands, who's been to the HSA in the last year? Most of us, right? All right, so you pretty much know that the HSA is the largest healthcare system in the Cayman Islands. We have presence in all 3 islands. We have 2 hospitals, one in Georgetown and one in the BRAC Faith Hospital. We're a 124-bed hospital here in Grand Cayman and 18 beds in the BRAC. We have 5 ORs. We have 4 here and 1 in the BRAC, that's operating rooms. And we have 6 district clinics. We are in West Bay, Georgetown, Bordentown, East End, Northside, and Little Cayman. What we've done early is that we have put all the records of our patients in an electronic form, and we have a electronic medical record that spans all venues of care. So our clinicians are able to electronically get to patient information from wherever they are. Sometimes they do it remotely, most times in the hospital. We've had the Cerner product that we use for our electronic medical records since 2003. So we have a lot of digital data on our patients. We have all our labs. We have radiology that's digital also. And we do this for inpatient and outpatient settings. Even our clinical notes are in our medical record, and they're all digital. We offer primary and secondary care, and we do have accident and emergency. Most of you know that. We're responsible for public health. We do surveillance of disease across the island, and we do immunizations. I'm setting the stage for why we needed a patient portal and why we need to engage our patients. I saw a lot of hands go up a while ago, so I'm going to give you some stats on how we did last year. We saw over 38,000 patients at the HSA across all the venues. We had nearly 500,000 patient touches. Our accident and emergency department saw over 32,000 encounters, and we did OR procedures in excess of 3,000. We have about 800 plus employees. Can the employees raise their hands that work at the HSA? I want you to give yourself a round of applause. This is tremendous work that you've been doing. And even more reason why we need to engage our patients. Our strategy when we started the patient portal, I won't come down because I'm a little short, so I don't think you in the back will see me. When we started our strategy, we wanted to empower our patients. Yesterday, the speaker talked about empowering your patients, letting them have information that will better help them to adhere, to be compliant. So that was our strategy around our patient portal. We wanted it to be very simple, and we also wanted it to be convenient. So what better way than to give them a website, which is pretty simple and accessible from all venues, because we all go on the web every day, either on our phones, on our PCs, at work, at home. So the patient portal was the right thing to do. When you open our patient portal, when you log in, right away we give you your pending results, or your last results, sorry. And that is one of the things that we find that patients like. They like the fact that as they log in, they can see their results. So if because we're electronic and integrated, our lab results gets posted quickly, and they are available in the portal right away. So here on the right-hand side, as you log in, you see the results, and we have your patient profile also. So we're showing all your immunizations. How many of us know when we had our last tetanus shot? Here in the portal, you can find that. I remember I went to the accident and emergency department once, and the doctor said, "When did you get your last tetanus shot?" And I was like, "I don't know." So good that I had the portal, I could refer back to that. We have your current allergies and health conditions. Here I want to highlight that we have learned more about your conditions, because we have a lot of patient information in our portal, and it's written so that the patients can understand it, because here it says arterial fibrillation and flutter. Most patients don't know what that is. So when they click this link, they get information that is written and it's patient friendly. One of my next slides will show you an example of this. Here is results. So since we've been on the electronic medical record from 2003, if you log on to your patient portal, you can see results all the way back to 2003. So that's a good thing for us and for our patients. So I remember the first time I logged on and I looked at my cholesterol levels, I could trend it and see how I was doing. And as soon as I saw it, I realized that I needed to do more exercise, eat better, and now I myself became an engaged patient. Messaging, James talked about messaging. We allow in our portal for you to message your providers and your providers to send messages back to us. So we have an inbox like you would see in Gmail or Hotmail or any other mail application that you have. And we also have appointments. You can view your upcoming appointments, and you can schedule and direct book appointments for the Georgetown Clinic, the Georgetown General Practice Clinic. We do appointment requests for other areas, but you can actually direct book, take your time slot that is appropriate for you for the Georgetown Clinic. My hope is one day that we'll do more direct booking, because our patients are asking for it. And as I tell you more about our future, I'll show you some of the suggestions our patients are coming back for. So in the portal, there are more things that I could go over, and I could talk for days on the different things that we have in the portal. But we do have a booth outside that is manned, and they can show you all these details and more in a better way, and that will allow you to get more information about this. My slides will be presented at the end of the conference too, so you can take a better look at this. I talked about patient education. What the patient education has is it has diagrams that make it easier for the patient to understand, and literature that is very easy to read. And we encourage our patients to use this, because a patient who understands how to take care of themselves will do better at compliance. I would be remiss if I didn't mention the patient portal team. We have a small patient portal team, and is Debbie Harding and Sean Cohen in the audience? Could you please stand? They have worked hard to give you those features. They have promoted it, and they have worked tirelessly to get us to where we are. We started 4 years ago, and every promotion that we've had, either Debbie or Sean has been there, and they have made sure that the portal gives us all the good features that it has. I would also like to mention the marketing team. Recently, Dr. Thane has joined the group, and even more recently, the health information team is helping us with a new part of the portal, which I'll mention later in my presentation. But I would like to say that the marketing team also has helped us with the promotions, and we're expecting that over the next year that they will push even more, because as many of you haven't signed up for the portal yet, I'm expecting that with good marketing, we'll get more people into the portal. All right, why did we choose Cerner portal? The reason why we chose the Cerner portal is that it was already integrated. We had the electronic medical record from Cerner, so it made sense to use their portal because it could connect easily. So we're able, as you saw, we're able to show our labs, we're able to show radiology results too, and we're able to securely message the provider and the patient and, both ways. The features were great, but what was even more impressive is that Cerner takes the time to take security very seriously. So from a cybersecurity point of view, the Cerner team, they do several tests on the system to ensure that your information remains safe. We know that all our patients want to know that their information is kept safe, and therefore, the fact that Cerner does these tests, what they do, they get a third party to try and hack the system, and if they're not successful, or the results of that, they patch it to make sure that we remain secure. They share their annual audits that they do on the system, and what that does for us, it gives us a sense of security to know that they're keeping our information safe. Lastly, they're patient-focused in their roadmap. As you saw, video visits, that's things that our patients are asking for. I would like to personally use a video visit when I have just a common cold and I just need a quick prescription. I know many patients have asked me, when are we going to do that technology? It's new in the States, but I'm sure that we will be able to use it here also. When we launched, like James said, we were one of the conservative healthcare systems where we did limited results. A few of the results we would share with our patients, but since then we have decided that we will share all your results except for things like HIV, which we think that it's better for a clinician to have a dialogue with you before you see that result. But we are now offering all of the results that we have in our labs. The other thing I wanted to mention is that Patient Portal, when we launched it, it was only available for adults over 18. And that, what we heard after we launched is that the parents want to see their children's information, so we had to find a way to give the parents access to the children's information. So people under 18, those parents are asking us for what we call proxy access. And we are going to listen to that cry, and we're going to launch proxy today. So a little bit about our journey. Thanks. A little bit about our journey. The first patient portal in the English-speaking Caribbean, we launched on the the 17th of November, and we branded it My HSA Patient Portal. We did extensive marketing. We trained internally our staff, and the minister at this same conference delivered the announcement. After the conference, we checked to see how well we were doing. We sent out 161 patient invites. By the Saturday, only 35 had claimed the invite. So how it works is that we get your email address, we send you a sign-up email. You have to verify your email address by clicking a link, pretty much like any online service, and then you get access to the portal. So when we saw this number, we were thinking, oh, it doesn't seem to be working well, and we were worried. So 2 weeks later, we did a lunch and learn session at the HSA, and we decided that we'd push again internally to see if we could get more signups. By this time, we got 192 patient invites out, only 54 claimed, and we only had 3 requests for appointments and 1 message to a physician. So we were starting to get worried that even though we're doing this promotion, we're not seeing the gains that we want to get at. So what we did is in 2015-16, we went on a promotional push. We went to, we promoted within our staff, we went on the TV's station, we went over to the BRAC, we went over to government admin building where most of the civil servants who are our main customers are, and we did a face-to-face meet with our patients to see if we could get more signups. We even went to Public Works to see if we could get more signups. So during 15-16, there was a lot of push for the patient portal. What we did also in the meantime is that we added some additional features. As I said, now we have more labs, we have scheduling, we have appointments for physio and specialists on the portal. You can book those. And we in December of 2016, we allowed radiology results to be pushed to the portal. In 2017, we launched 2 apps, one in the Android and one in the Apple iOS Apple Store. So now we can be on your phones. So if you sign up for the patient portal, you not only have the web interface that I showed you earlier, but you now can have it on your phone. So you can put it beside your WhatsApp icon so that you can stay engaged with your healthcare. We retrained our staff at the registration points, and we put the registration for the patient portal in their workflow, because before they had to go to another screen, so we wanted to make it easy for them to have that dialogue with you when you came to register. We went back on air at Radio Cayman and did some more promotions this year, and again, we're here at the conference. So we have a booth outside. If you haven't signed up, sign up for your patient portal. The results are in there as soon as they're posted. We posted at the HSA, we post them to your portal. It's connected. It's one seamless system. So, and there's a lot of patient education in there, and we are going to launch medication information in your portal too, so look out for that. So if you have been on the inpatient setting or had a visit with us, and we have meds, medical information about you or pharmaceutical information about you, it will be pushed to the portal, and you will get extra information. You know, you get prescribed these drugs and you don't know what the side effects are. You don't know the full reason why they were prescribed because you had a short encounter with your doctor. That sort of information will be in the portal for you. So please sign up. I can't say this enough. Get engaged in your own healthcare. I didn't mention that we put Google Analytics in our portal, but for those of you who don't know what Google Analytics is, Google Analytics allows us to track how our patients are using our portal, where they're logging in from, which browsers they're using, what devices they're using. Are they using the iPad more than the Android? What are they using? So I said I'd share a little bit of that with you. Here is one a report from the Google Analytics for 2018. We see that, as we expect, most of our users are coming from Cayman, but we're getting users coming from Jamaica, the US, and even as far as India. And I should do a little bit on this side too, even as far as India. So I suspect that our patients who are Indian and are going back to India, they're checking in on their patient portal. Maybe they're seeing a physician in India and they want to share something with that physician. They can use the portal to do so. All right. Here, this is how we've been doing in terms of people claiming those invites. So we launched in 2014, and I'll come down for this one. we launched in 2014, and say so that I get you guys engaged on this side. We launched in 2014, so just in November. So the green shows the patients that have claimed, the blue shows the people that we invited, but they haven't claimed their invite yet. And when we did the promotions that I talked about in 2015, a lot of face-to-face, going to the different people and talking to them in their venues, we found out that we got a huge spike in the number of people that signed up. We thought that would keep trending upwards, but unfortunately, once we stopped the promotions, it dropped down. So in 2018, now that we've changed and we only recently changed the workflow of the registration staff and also retrained them, we see it starting to trend upward again. And I'm sure after the conference, that is going to take another spike, because now that I've explained this to you, I'm expecting that you will sign up also. Okay, so far we have only had 842 claimed invites, and like one of James's slides said is that it seems like even though there's a lot of information and it's easy for patients to get engaged, it's still hard for us to get you over that barrier of actually getting the portal on your devices. So what are the lessons learned? The lessons learned is it's really not easy to get our patients signed up. We noticed that when we talk to patients, the ones that actually sign up, they love the benefit, they like to track their history, they like the fact that they can see their results even before the doctor gets to them, they can see their results in their portal. They like the fact that there's patient education in there. They like the fact that they can book their appointments when they want to book their appointments, when they're sitting at their desk, at work, or wherever. They like the convenience, but it's getting them signed up. That's the problem. So what do we need to do? We need to do more face-to-face sign-up. We need to talk to the patients when it's relevant. We found out that when doctors are in their consult, if they take 30 seconds and just say, hey, do you know that your results will be posted to your patient portal? Go sign up. That few seconds will start the engagement of the patient. So we're asking the doctors, please help us to promote this journey. I told you that patients are asking for proxy, and we will give them that. We need internal champions. So I know a lot of you work at HSA. We've been given Dr. Thane as the champion from the doctors, but nurses too. And we need more doctors to help us with this journey. So I ask you to help us sell this to our patients. And last but not least, patients only log in when there's a reason. If there's new results, they have an appointment coming up, or they want to check and review information, that's the time that they log in. So what does the future hold for us? We want our doctors to talk about this in the consults. We'll do more on social media. Yesterday, we put a big ad on the back page of the circular that was on everybody's seat. I hope you saw it. It was a nice full page ad provided by the Compass. So we are going to continue the promotion. Then what does the future hold for us in terms of additional things that we will do? I told you we launched patient proxy today, so you can get your kids' information. We also have launched U.S. Spanish, so the site is available, and you can see the Spanish translation is fully translated into Spanish in the language that some of us speak naturally, so that is something we also heard people asking about. And doctors have been saying that they have Spanish patients, and this is a good way to engage them. We are allowing you to update your information. So if you see anything wrong in your portal, you can make an update and send it back to us, and we'll correct it. We're hoping that in the next couple of years, between 2018 and 2022, we will do video visits. Well, it will be up to management to see if we can do it, but we'd like to do video visits, and we'd like to one day share the clinical note with the patient. I know a lot of doctors are wary of that when I speak to them, but more and more patients are asking for it. And as James said earlier, if they go to the health information department, they can just ask for it and we will give them. It's a small cost, but it's not prohibitive. So if we can give it to them there, we can give it to them in the portal. Well, with that, thank you for your attention.
Thank you very much for that presentation, James and Keith. I do have a small token of our appreciation to present to you, which has been very generously sponsored by Kirk Freeport. Can I get another round of applause for our speakers, please? I also want to recognize our minister, the Honorable Dwayne Seymour, who has joined us this morning. Welcome, Minister. Thank you for coming. And I did see MLA Kenneth Bryan earlier, but he's stepped out. So how's everybody doing? All right, you all just chomping at the bit to go next door and get your flu shot, maybe sign up for the patient portal, go enter for the Fitbit competition for the Pinnacle Media. Well, listen, we are now at our coffee break, which has been very kindly sponsored by Aetna. Don't forget to visit all of our exhibitors and stop by. You've got the flu shot and the blood donor clinic. There's also a health check. Make sure that you're back here at 10:45 because we have an awesome panel coming up right after the coffee break and you don't want to miss a thing. Enjoy the coffee break. I'll see you back here in 15 minutes.